Good evening and welcome back to Progressive Soup. My name is Emily Walton-Testa and I'm here with David Stevenson, and today we have Dr. Spyros Smith as our guest, and he's a medical doctor who also specializes in integrative medicine we've been talking about. And one thing I would like to bring up again is at Danbury Hospital, they're starting the Plane Tree project, and I had gone over as a massage therapist. I was doing some hand massage, and Peggy O'Shea, who's a nurse at the hospital, she's head of the complementary medicine and the cancer unit. They're implementing this program to making healthcare a more patient-centered approach. Would you like to talk about that?
Sure.
Yeah, go on. Yes.
I mean, how much do you know about the plane trees? What is the...
Well, as far as I've gathered from it is that what they did was they sent out a letter to the employees of the hospital, and they said if anyone's interested, we're going to start this program to train all the employees to make healthcare more patient-centered and more hands-on.
A more personal approach to it. More empathy.
Right.
A more empathic approach to it.
Right.
A more individualized approach,
right.
etc. That's how Plane Tree started out in San Francisco many years ago.
Right.
And then kind of spread through the country, where they set up little units or big units in some hospitals that had that patient-centered approach. It's hard to do it with a whole hospital because it's very costly, and the Plane Trees initiative involves making the rooms more human in hospitals.
Okay.
Whether it be through artwork, through paintings, etc. They make it almost like a room at home versus a room in a hospital.
Okay, like an assisted living center.
Exactly. So there's money that goes into developing to beautifying the area where these plane tree models lie, as well as education of the staff, of course, to have a more personal and more human approach, if you will.
Right.
Not to suggest that the rest of the hospital is not human, but to make the extra effort as if it were your family members sitting there or lying there on the bed.
I know my stepmother, she's a nurse, case manager at the hospital, and she's saying with Plane Tree, a lot of the nurses are complaining because now with Americans, we have that sense of entitlement. The customer's always right, and some patient wants their nurse medicine at 11. They don't want to be woken up at 6 a.m. to take their medication, and the nurses are complaining, saying, well, it's difficult. We have so many patients to take care of that it's more difficult for us.
It's very difficult with the constraints of the current healthcare system in the U.S., where there's a shortage of nurses, there's a shortage of internists, ancillary staff, to implement programs like that for those exact reasons.
Right.
That nurse may have 6 patients, 5-6 patients on average, and has to administer, on average maybe 40-50 medications in a short period of time.
Right, of course.
So it's very hard to do. But even under those constraints, the ability to discuss that with your patient in a soft-spoken approach, if you will, where you're not confrontational with them, where you don't say, well, look, I'm busy.
Right.
I've got other things to do. I've got people that are seriously ill.
Right.
Your disease is just as important to you, whether it be life-threatening or not.
Exactly.
And so just the explanation. And sometimes, I found in my practice, and I practice at the hospital as well, both internal medicine and hopefully soon some integrative medicine as well.
Right.
I find that if you discuss it, if you're human and sit down with that patient and have a conversation with them and explain the deficiencies, either of the system or your own deficiencies or what have you, they accept it and work with you on that. And they'll be grateful at the end of the day that you treated them with respect and you sat down and had that conversation with them.
Exactly.
And afforded them your time. Even though you may be busy, it takes a few minutes.
Exactly.
People overestimate the amount of time needed to touch somebody.
Right.
With some people, a little lady from Sicily I saw the other day, just touching her on the shoulder and saying, you're going to be okay. I'll come back later and talk to you.
Right.
Can't do it right now.
Yeah.
But I'll be back in an hour or two, versus saying, look, I've got to go. I've got somebody who's a lot more serious. I'll be back later.
Exactly.
That kind of an approach. So that's really what the Plane Trees and other models, it's not just the Plane Trees that are doing it.
Right.
as we discussed earlier, there are a number of initiatives throughout the country now in big university centers, with certain centers like Duke and Cleveland at the forefront of this type of medicine, if you will. In fact, the Cleveland Clinic has appointed what we call a chief experience officer, who's a former hospitalist, hospital internist, who knew the nooks and crannies of the hospital, the deficiencies of the hospital, and what she does is she walks around, her name is Dr. Duffy, she walks around the hospital identifying situations like this, deficiencies in care. She helps through healthcare navigators, as they're called. She helps families deal with illness and work their way through the healthcare maze. You're getting this test and that test. What does this all mean? My doctor didn't discuss it with me. She's educating staff about that. So there are a number of initiatives like the Plane Trees that are really taking off and trying to give a human face to medicine and integrate disciplines such as massage, nutrition,
Reiki,
Reiki, acupuncture into these center, in the medical center itself, not just as on the outpatient level. At Cleveland, for example, they send massage therapists into their post-cardiothoracic surgery patients, open heart surgery of any sort, whether it be valve replacement, coronary artery bypass grafting, and the massage therapists help, when you're on the table for several hours in a certain position with the surgeon operating on you, you're going to get a lot of muscle strain and spasm. You don't have to, but there are a lot of patients that suffer from that. And so these people help through relaxation techniques, massage, etc., to make things better. And they're now doing research in these centers to prove that they're more effective than the traditional means, which would be a muscle relaxant in the form of a pill or a narcotic to take away that pain. And they're showing at least 30% reduction in use of medications with these alternative practitioners.
What's what they do with the foot? What do you call that?
Reflexology.
Oh, that's right.
Yes. No, it's true. Like you said, they're using less opiates. They're using less, sleep aids.
And what I tell my colleagues is, if you were a patient, sitting in that bed, which would you rather have?
Exactly.
The Plane Trees model or the traditional model of care, where somebody.
Wait! You guys are the doctors. I'm the patient. You need to ask me that question. I'm the patient.
Yeah. What would you rather have?
Professional patient, by the way. I would rather have the one where doctors actually communicate and tell you what's going on and hold your hand for a second.
Exactly.
I mean, that's It just seems much more humane and much more. It'll accomplish a lot more, in my opinion.
And the healthcare practitioner wants that as well if they're a patient. And that's why have double standards?
Exactly.
What you wouldn't do on yourself or your loved one, why you don't do on others?
Exactly.
So most people, especially in community hospitals, and Danbury Hospital is a community hospital first and foremost. So most people there have that sense of community. They know that they're going to see David on the street or in the supermarket or Dr. Smith somewhere in the supermarket, etc. So there is a sense of family. So it's easier done in a community center than it is in a big university hospital.
Like you're in medical school, do you learn to go to the bed and say,
bedside manner.
Well, where do you learn that in medical school? What point? What year is that?
You don't. Actually, you try to emulate your mentors in medical school.
So you perpetuate
the behavior that you're taught, and that could be a good thing or a bad thing, depending who your mentor is. So again, that's another initiative now in medical schools. Up at Harvard, Jerome Groopman is looking at how to incorporate bedside manner into medical school curriculum. How do we make it? And one way they're doing it, they're trying it through literature. They're having their medical students write stories of a patient they've seen, and try to empathize and write a story about the whole from beginning to end through that patient's care, and then discuss it and get emotional about it. It's okay to bring out feelings and try to push bedside manner in that sense. It's an experiment. Nobody knows whether it can't be a bad thing.
Well, even in massage school, we had to go work with, with Alzheimer's patients, or, they sent some people to work with people who were disabled, just to have that experience. Volunteer, to have that empathy, to work with people who, I think any kind of student in any health field should have that experience.
And some of the best some of the most profound diagnoses in medicine, some of the the best information you can obtain from your patient is taken by the history when you sit down and you bond with that patient.
Exactly.
It's not by chance that the professors, the old-time professors would say, 80-85% of your diagnosis will come from that history if you bond. My mentor, Dan Mackin, who was Eisenhower's cardiologist a long time ago, now passed away recently last year, would spend an hour and a half with every patient in his office, and people would look at him and go, "What are you doing?" He said, "Look, I want to know what makes that person tick."
Are you treating people that are second or third generation, working backwards, obviously? Are you treating multi levels of generations in your practice? Because we talked about, you talked about in Italy how the doctor knows the history of the family. He knows what the history of what grandmama had and what the parents had, and can deduce a lot more from about what the children have based on the previous generations.
And a good internist should do that. I practice hospital medicine, so I rely heavily on folks like Dr. Volpin-Testa. To give me a story and give me the elder, yes, my apologies, to give me the essence of what that person I need the essence quickly because I'm treating somebody very ill with severe pneumonia, sepsis, stroke, heart attack, that sort of thing, so I need the essence quickly, so I'll get them on the phone, and the benefit of being in a community again is that I can get them on the phone and say, "Hey, tell me what give me the juice on this case." But you're absolutely right, and a good internist, a good GP bonds with generations, treats the father, the child, the grandfather, and that's the beauty of medicine. Whether you call it integrative or allopathic or whatever term you put on it.
Now, when I have my intake with my clients too, sometimes they'll reveal something. Oh, I forgot I had this. It might have nothing to do with my problem, but 20 years ago I was in this traumatic accident, and then you thought, wow, that could definitely have something to do with what you're dealing with. But they think it's nothing. They just mention it offhand.
And most GPs nowadays don't have the time to sit down with you and talk about these things. So the easier solution is here, take the antidepressant, and it'll work.
So the chart doesn't reveal very much, does it?
Nobody sits down to talk to them. There was a fascinating fellow psychiatrist that we met up in Minneapolis when we visited Allina Healthcare, which is a consortium of 25 hospitals in Minneapolis and the surrounding areas. They have a beautiful integrated medicine program, both inpatient and outpatient. And this psychiatrist, who's a behaviorist, is a traditionally trained psychiatrist that has a waiting list of about 500 people to see him. And he'll give medication as a last resort. He's not against giving antidepressants, etc., but he'll sit down for hours on end talking about depression and explaining to people that, look, this antidepressant will keep your serotonin, which is the neurotransmitter that you try to prolong by giving you try to prolong the time that serotonin is between your nerve endings to keep you happier. A simple way of looking at it. What it doesn't do is replenish your serotonin. So he talks to them about diet, the food groups that they could be eating, and educates his patients, along with psychoanalyzing him and occasionally giving him medication.
That's the serotonin. Is that like the stuff in the bottle, Serotan? Where the advertisement is it's nature's remedy because it's nature's spelled backwards. Are we talking about the same stuff or something related to that?
Serotonin is a neurotransmitter. The precursors to it are found in bananas, nuts, tryptophan, etc. Is the
tryptophan.
Right. So trying to replenish that in your diet is just as important as taking that antidepressant. And again, that goes back to what we were discussing on the first part of the show, that the education regarding your health, your nutrition starts at home. My wife Lisa educates the kids every day. This is what we need to be eating. It starts at home.
Exactly.
And mom and dad need to pick it up somewhere, whether it be their doctor or their nutritionist, whoever they choose to see.
Does she ever send some gummy bears just to let them know what just to let them know what the other side of the other kids are going through and why they're all
you shouldn't be eating.
Your taste buds acclimatize to what you eat. And I'll give you a very good example. I used to drink lattes all the time, and I had an issue with my intestine many years ago, and I cut out dairy products. So about 3 months into having soy, because I couldn't tolerate lactose, I go to Starbucks. I order a lot, not to advertise anything. I just happened to be going by there. I picked up a latte, and they mistakenly put milk in it. And let me tell you,
what kind of reaction
I tasted it and I said, "Oh, what a smell!
Right.
What is this? It reeks."
Huh.
And I realized they'd put milk in. I said, "But I had this for 20 years, for 25 years, whatever the number of years I used."
Yeah.
So my taste buds had deacclimatized, if you will, to the taste of milk. Same goes with children. Children will eat, and natural food is not bad tasting food. If anything, it's you buy an organic tomato, or you have a tomato in Sicily or Greece, where we're from, and it's got an aroma like no other. And then you buy the greenhouse tomato, and you say, "What's this?"
Yes. Exactly.
So that you train your kids.
If not worse.
My son will tell you if he sees you eating a strawberry, is it organic?
Right.
And you'll say, "Oh, come on, poo-poo, what's this? What are you talking about?"
Right.
And he'll tell you, do you know they spray that stuff with fungicide?
Right, and
That's called methyl bromide that causes liver cancer in rats.
Methyl bromide? He said methyl bromide?
Yeah, he is, because he's in 7th grade now. He's learning about chemistry, etc. And he's been hearing Dad talk about it and Mom talk about it. And Mom emphasizes at the hour of food at home, and when we prepare food and buy food at the supermarket, so it becomes second nature to the kids. It's not something you're ramming down their throats and saying, "Do this or else." It's an educational process. You can taste. We don't inhibit them from eating anything they want to try. They've tried a donut. They've tried this and that, and it tastes good. But they realize that it's junk.
Exactly.
It's not good for them.
They don't call it junk food or nothing.
So
Unfortunately, it's so expensive now to eat.
It's become a lot cheaper than what it used to be. When I started out in the 80s in college in California, if you bought organic, there it was at least 50% more expensive, 40-50%. Now it's come down to a margin of about 10-15%. So it is more expensive, but when you look at it, you can prioritize. You can say, well, anything that's in the ground, potatoes, onions, anything that's a ground dweller, carrots, is going to pick up all the fertilizer, pesticide, all the toxicity of the soil. You don't do that. If you have a banana that has a hard exterior, watermelon, it's on the ground, but it's got a hard exterior. It doesn't soak up that toxin. You take something like a peach. Somebody sprays something on that peach. It doesn't matter what you do to the outside of that peach and wash it. It's soaked in because it's porous. So you're getting a lot of toxins, and nobody looks at this. The FDA doesn't. The USDA doesn't.
Exactly.
They don't look at any of these. About 2% of the products used in agriculture are checked. And nobody knows what the long-term consequences are. So here we are saying, well, we've checked our medication and this and that. And people are spraying things on us left and right, and we have no idea. And that goes to cosmetics. There's no end.
I know.
For local grocery shoppers, I want to just throw out a plug in for my friend John Holbrook down on Turkey Plain Road, Route 53 in Bethel. John has essentially all organic, and except for the milk. Now the milk is like 100 times more expensive. The natural milk, or whatever you call it, is 100 times more.
Raw milk.
Yeah, raw milk is really expensive. I haven't even tried that. It's so expensive.
Right.
But the vegetables and things are just magnificent. And only a little bit more. Like you say, it's only 10-15% more. But if you're getting something that you like, you might as well pay a little extra.
You like it, and it's healthier for you. You're not putting the toxins in your body.
And you won't throw as much of it out.
Right.
You eat a crappy peach and you take a bite out and say, "Oh, what the hell is this?" And throw it out.
Exactly.
And the chances are, even if it's not certified organic, if you're buying it from a local farmer who respects his land, who's known, you're not going to get as much chemical in that as you are if you buy it from Chile or Mexico, etc. It's again, you're putting it in your body. You should respect your body. Should be your
body's your temple.
Your temple, right?
Yeah. I think another scary thing too, all these artificial sweeteners, aspartame or sweet and low. I mean, they're rat poison and they're causing cancer and carcinogens, but they're allowed to get away with it because it's like a food additive. It's not considered food, or somehow they're getting away with these.
The biggest concern with sweeteners isn't so much that they cause cancer, which they may. But if you look at saccharin, for example, and you look at the studies done with saccharin when they said, saccharin causes cancer in rats, they gave doses that were, 200, 300 times the dose you would take in your coffee. Who knows? If you gave 200 times a dose of vitamin A to somebody, you'd cause toxicity. That's not so. I mean, there's a concern there because we don't know what the long-term effects are. So you're right in that sense. The bigger concern is that when we have these sweeteners, fructose, high fructose corn syrup, aspartame, etc.
Exactly.
You're not triggering. Science knows that you're not triggering. We figured this out. You're not triggering the satiety center in your hypothalamus, in your brain. So you're having fructose, and you're using it as a substitute. If you use sugar, that sugar would trigger a hormone that would go up to the hypothalamus and say, "Hey, I'm full." You don't get the same response from fructose.
Fructose does not send a message to your
Correct,
brain.
and nor do the sweeteners, for that matter. Sweet and low, aspartame the whole. So you keep eating and eating and eating, and the chances are you're going to get 10-20% more calories from that food because you haven't triggered the satiety center in the brain.
Right.
And so there's a lot of research being done with that, with leptin, which is a hormone that is secreted by your fat tissue, your adipose tissue, that goes up to your hypothalamus and says, "I'm full." And why do some people have? Some people are resistant to the effects of leptin, because when leptin first came out, and leptin was one of the reasons I got my job at Danbury Hospital. It's a funny story. But I was down at Johns Hopkins doing endocrinology, and leptin had just come out in 95 as a marker. So I heard about it. Then I interviewed up at Danbury Hospital, and the chief of medicine wanted to be a wise guy. He just read about leptin and asked the question. He says, "Well, who knows what leptin is?" And here's this little hand at the back of the room that says, "Oh, leptin is this and this and this," and he just stared at me for a while.
Right.
So leptin is a satiety hormone, and science isolated it. Leptin, L-E-P, satiety. What makes you feel full? Satiation.
Gotcha.
So, people said, scientists said, great, let's market leptin, let's produce leptin, and give it to people, and they'll lose weight.
Right.
Well, they did that, and nothing happened. They said, why? This doesn't make any sense. And then they figured that there's a resistance.
Yeah.
You need a receptor. Leptin has to touch on a receptor and activate something in the hypothalamus to get that going. And so people that are obese actually have resistance to leptin. They think. Again, this is all in the forefront of science now.
They're talking about.
This is the fat hormones.
Okay, but now
fat genes are a different story.
Oh, okay.
Yeah. So it's a whole science, and we can spend hours and hours on it.
Okay, that's another show.
That's a whole other show.
Well, that's so fascinating. I hadn't heard that thing about that. Oh, it's fascinating.
So that's where sweeteners come into. That's the fear about sweeteners.
I wouldn't be surprised if food companies are putting these in their foods in purpose.
Well, high fructose corn syrup has gone into foods for that exact reason. One of the reasons is that. The other reason is it's convenient. It makes food taste better, and they can mass produce it.
Yeah. There was some thing about Nixon wanting to do corn growers. It was for the corn farmers.
Oh, wow.
And he did it on purpose.
Yeah.
To make them make more
That's
money.
Very true. Well, what they did was they produced more corn.
Okay.
And they genetically modified corn, produced more high fructose corn syrup. It was an easy commodity, and therefore it went into the food industry and saturated the food industry, so that anything you pick up in the supermarket has some form, cornstarch, maize, this, that. Maltodextrin comes from corn, etc.
McDonald's Big Mac, 57% corn.
Right.
Wow.
Absolutely. And genetically modified corn, usually.
Now, you made that analogy on the first show between putting gas in the tank and putting food into your body, but there's the common denominator. Yeah. Corn in the gas tank.
Right.
Corn in the body.
Could this have been affected by commodity traders? I mean, am I being cynical and thinking run by the market?
I don't think you're being cynical. I think it absolutely is run by the market, or the whole food industry is. And some say, and I haven't confirmed this, but some say that the people that run the USDA had come from agriculture and big business, or at least several members that are on the board there.
Yeah. And if they put stuff in cigarettes to make it more addictive, I mean,
why wouldn't they put it in food?
Right.
So what I tell my patients is, if you go into if you go into the supermarket, first of all, never go into the center.
Right.
Stick to the aisles, because you're going to get produce on one side, you'll get the dairy products and fish and meats and that sort of thing. Don't go into the center, because you get your processed foods.
Exactly.
Anything you pick off the shelf, and don't go buy natural and whole wheat and this and that. That has more than maybe about that much in the way of ingredients on it, and I'm for those that can't see, I'm doing about an inch here. You throw it away.
Right.
You're going to have a ton of additives in it, and they can't be good for you guys.
It's depressing. I know.
Come on, let's end it on a cheery note. We're down to 5 minutes. Come on, a little cheer.
But it's good to feel
the cheery note is that people are waking up to all of this and are reading more. With the one good thing that came from the internet was that people became more educated. They can they can look up websites and say, well, what is this? It's at their fingertips. Where in the old days you'd have to go to a library or a medical library, etc., to look all this up. So they're becoming more educated and they're asking more intelligent questions, and they're putting doctors in a lot more difficult.
Like, I don't have time for this. Like 50 papers.
You guys got to keep a little bit now, huh?
Right, exactly. Yeah. So that's good stuff. I mean, I think that there's certainly progress, and we have become a nation of obese people.
And diabetes.
And we have children now that are diabetics at age 10, type 2 diabetics, which is something you get in your 50s and 60s.
I know.
30% of the population is 30% is morbidly obese. About 50 to 60% is overweight.
I was close to that type 2 diabetes. I was on the verge of that, and thankfully, because of Ted Blum, he kept hammering away at me, and I guess him and a lot of other people.
Well, and you can turn your cardiovascular risk around just with a 10 to 15% drop in your weight. You don't have to reach fighting weight to reduce your risk. Or your need for medications or all that. So good example of a good internist and a good patient. You need both.
Exactly.
It's a marriage. You can't have it lopsided on either side.
What about young children? I know a lot of young children, 2, 3, 4, with juvenile diabetes type 1. Now, can that be affected by diet?
Well, that's a more difficult nut to crack. And you certainly want a good diet in a type 1 diabetic. You're not going to cure type 1 diabetes until you can isolate the gene and take it out and change it. But you can certainly affect the longevity of that child or that person by eating the right foods.
Because sometimes it's parents that don't even have diabetes, and they have children that are diabetics. So is it a genetic thing at that point?
It is a genetic thing. It is a genetic thing. And there we
Host, it's time to wrap up the show.
Okay, sorry. Well, we've just arrived at the end of our show. We have about 1 minute 30 seconds left. Okay, and I just want to thank our guest today, Dr. Spyros Smith, who is a medical doctor with a specialty in integrative medicine. Thank you for having our show. And again, my co-host, David Stevenson.
Thank you, my Buddha.
And my name is Emily Volpentessa. Thank you for joining us today. And we'll see you next time on Progressive Soup. Thank you. Have a good night.